Hello, good day, everyone. I'm Dr. Katie, your radio hall. There is something for us to learn today. Of course, that's why I'm here. This is especially for the residents in anesthesia and intensive care. Before I leave the OR, let me give you this rapid sequence induction. You don't need to cram it, just enjoy it, okay? Rapid sequence induction, from that name, is a form of induction and airway management in anesthesia that becomes necessary when your patient is at risk of gastric regurgitation and pulmonary aspiration. What class of patients is at risk of gastric regurgitation and pulmonary aspiration? Clinically, they are referred to as full stomach patients. Which class of patients are full stomach patients? One, anything that will increase intra-abdominal pressure will translate to raised intragastric pressure, which will predispose your patient at risk of gastric regurgitation and pulmonary aspiration. All right. So rapid sequence induction was born out of safety. It is aimed at quickly securing the airway in a patient at risk in order to prevent aspiration and the morbidity and mortality that is associated with pulmonary aspiration. Okay, what is pulmonary aspiration? Pulmonary aspiration is the breathing of orogastric content into the airway. It can be fatal. There are several things that is associated with that, which is dependent on the amount of content that was aspirated, the acidity or the pH of the content that was aspirated, the matter, the mass of what was aspirated, the time of intervention, and the presentation. All that will determine the pathophysiology of what will happen when your patient aspirates, but that is for a different lecture. We're talking about rapid sequence induction. Rapid sequence induction is indicated when your patient is full stomach. As people who are full stomach are, one, intestinal obstruction, intra-abdominal tumor, massive ascites, and then emergency. Emergency for two reasons. You might not be able to ascertain the history of the last time your patient ate or the effect of stress hormone that was associated, the hormones that were associated with that stress that brought the patient to the hospital, because they delay gastric emptying by prolonging gastric emptying time. For example, a patient who ate breakfast by 8 a.m. had an accident by 8:30 a.m. and presents in the hospital by 5 p.m., maybe from a very far place, and you begin to think that because the food was in the morning, you expect that the gastric content would have been emptied. It is not true. This is because the cortisol, the glucagon, the catecholamines, which are referred to the stress hormone, they will prolong gastric emptying time, therefore delaying gastric emptying. For that reason, an emergency patient is termed a full stomach patient. Diabetes, because of gastroparesis occurring from neuropathy, they are also referred to as full stomach patient. Full stomach patient, when we talk about people who are pregnant, for two reasons. One, the pressure of the fetus, the abdomen, will increase intra-abdominal pressure, translate to increase intragastric pressure, and predispose your patient to regurgitation. And for the other reason, pregnancy hormones, progesterone, and the hormones that are associated with pregnancy have been seen to cause the gastroesophageal sphincter to be lax. And when it is lax, they are at risk of regurgitation. That's why at term, most times, they are seen to have reflux. Okay, so when you have a patient that is full stomach and you are targeting to secure the airway quickly, what you have to do is rapid sequence induction. What are the things you require? The drugs that were used to describe rapid sequence induction are suzametonium and sodium thiopental, and these drugs were chosen because of their quick onset of action. Suzametonium is able to cause muscle relaxation in 1 minute, in few seconds, 60 seconds, within 60 seconds, while sodium thiopental is able to induce hypnosis following 1 to 2 ham brain circulation time. Most times in the ORO, we set our IV cannula here. And so when you give the induction agent, it goes first to the heart and the heart pumps it to the brain. So it does that 1 to 2 times before the patient is able to go to sleep. And that's why sodium thiopental was chosen. So anytime you have a need to now change these drugs in trying to give a rapid sequence induction, you now refer to it as modified rapid sequence induction. And when will that happen? For example, you have a patient who's hypovolemic, a bleeding patient, a patient who's hypotensive, a patient in shock. You might not want to use sodium thiopental because sodium thiopental will cause hypotension that will put your patient at risk of cardiac arrest following hypotension, referred to hypotensive cardiac arrest. So for that reason, you might want to use ketamine. And so it is no longer a straightforward rapid sequence induction. It is now a modified rapid sequence induction. And if you have a need to leave suzametonium alone because of its side effect in some procedures like someone with burns, someone with polio and all that, coming for emergency procedure, or intraocular pressure with penetrating high injury coming for emergency procedure, you might don't want to use susamethodium, you want to use chloronium or do some other practices, pre-coronization and all that, then it is referred to as modified rapid sequence induction. So when you have to pass NG tube to decompress the stomach before induction of anesthesia, before rapid sequence induction, it's also a modified form of rapid sequence induction. Have you done that? What are the requirements before the procedure? What are the requirements that are needed for rapid sequence induction? One, a teachable bed, because it is possible in the process of the procedure too, when you're trying to prevent regurgitation, it can still happen. So immediately it happens, you should be able to teach your bed so that there will be no aspiration. So you teach your bed. That's why you need a teachable bed, head down. And then you need a wide bore suction so that high volume suction, that's what I meant. High volume suction will be able to suction large particles, matters, granite, or whatever meal the patient had eaten before anesthesia or before surgery. Is able to suction it. Unlike the high pressure, low volume, like the Yankers that has a narrow mouth, it can take secretions, it cannot take large volumes or large matters. Okay, you need a high volume suction, and then you need oxygen, which is always there. Okay, and you need all the drugs. You need the susamethodium and the sodium thiopental that are drawn and labeled, those calculated, because those drugs are given in rapid succession. So you don't need to give them slowly. Sometimes we can titrate drugs, and when your patient is sleeping, you might not need to give the entire calculated doses. But you don't do that with rapid sequence induction. You calculate your drugs, you label them, and keep them because they're going to be given at a rapid succession. So when you have all these things done, you have your airway kits there, a laryngoscope, endotracheal tube, airway management kits, endotracheal tube of a size above, a size that is appropriate, and a size below, everything ready. Then you need the anesthetist that's going to intubate and two assistants. One of them that is trained on applying Selic maneuver, also refers to as Cricot pressure. Selic maneuver after the name of the person that discovered it or that brought about the practice. Why the Cricot pressure? Because of the bone, the Cricot ring or Cricot cartilage that is going to be applied, where the pressure is going to be applied. All right, it is chosen because the Cricot cartilage is the only complete ring of the thyroid cartilages. And because it's a complete ring, a Sennett ring, when you try to apply a pressure to a ring, instead of collapsing like the other cartilages, it will transmit its pressure to the esophagus that is behind it, therefore occluding the esophagus against the body of the C6 vertebra. And that, by thus doing, prevents regurgitation. All right? So the person that is going to apply that pressure should have been trained. All right? So by so doing, you must cancel your awake patient. You must cancel your patient that before the patient sleeps, because Selic maneuver is applied before the induction of anesthesia. And so there's a possibility that your patient will be awake before sleep and feels the pressure. So if you don't cancel your patient, telling your patient that before you sleep, there is going to be a pressure applied to your neck, is just to help you so that you don't regurgitate, your patient will feel doomed and be thinking there's a conspiracy that's going to kill the patient while on table. So you must appropriately cancel your patient to expect that. So having trained your people, and the last person is the one that's going to be giving the drugs, the one that's going to be circulating, and is going to be by the side. Having calculated the drugs and kept those things ready, then the procedure itself. The procedure of rapid sequence induction will include one, pre-oxygenation. Pre-oxygenation is done before the induction of anesthesia and muscle relaxation. This is because it is the only time you have to pre-oxygenate your patient. Every pre-oxygenation after induction and muscle relaxation of your patient during rapid sequence induction will ventilate the stomach and therefore increase the intragastric pressure and further put your patient at risk of regurgitation and then pulmonary aspiration. And when you are finished pre-oxygenation your patient, then you give the drug in quick succession. One, induction agent, sodium thiopental, followed by susamethodium, and then smooth laryngoscopy and endotracheal intubation of your patient. Don't forget, the application of a Cricot pressure might disturb the anatomy of the airway and sometimes makes it difficult for you to be able to intubate. So you must be able to guide your assistant that the pressure should not be so much, especially when you're already seeing the cord. You can relieve the hand a little so that the tube can go in smoothly. Once you are sure the tube is there, you have confirmed, you secure quickly and connect to the breathing circuit. That's the end of rapid sequence induction. But there are some common questions that they ask with rapid sequence induction. What do you do following Cricod application and your patient is regurgitating. They just want to know what you have to do, how you will apply those things that you have kept aside. One, you do a quick tilting of the head of the bed so that whatever is being regurgitated cannot go back to the airway. There will be no pulmonary aspiration. Then you get your wide volume suction and clear the airway and start all over again. All right. And they will say, what do you do with the Cricod pressure? The Cricod pressure following regurgitation, you relieve it so that your patient can completely regurgitate while you suction head down. Okay. Because if you don't remove it and the pressure with which the gastric content is coming is much, it could cause esophageal rupture, which will now cause the leakage of gastric content into the mediastinum, causing mediastinitis and worsening the mobility of your patient and making your patient worse than the patient came. All right. So you relieve your hand quickly to prevent this other pathway and then suction the airway and start all over again and intubate, secure your patient. Anytime you are doing what is different from susamethonium, sodium thiopental, and the NG tube, that's a gastral tube, then you now refer to it as modified rapid sequence induction. Hope you have learned something. Take that. I'll be with you again. Anesthesia and intensive care made easy. Follow Dr. K to your radio. It will never be a dull moment. Bye.